Hi, my name is Chloe Whiteside, and on today's Antibiotic Answers, we will be discussing acute otitis media. So first, what is acute otitis media and how is it diagnosed? Acute otitis media is commonly known as a middle ear infection. This is when we see an inflammation of the middle ear that can cause pain, discomfort, and fever. It is most commonly diagnosed in children, and a diagnosis is made when it is observed that there's a moderate or severe bulging to the tympanic membrane, or when there's a new onset of drainage from the ear canal that's not associated to acute otitis externa. Typically, this is caused by a bacteria or a viral infection. The most common bacterial pathogens of otitis media include Streptococcus pneumoniae, Haemophilus influenzae, or Moraxella catarrhalis. The most common viral pathogens of otitis media include RSV, COVID-19, influenza, adenoviruses, human metapneumovirus, or picornavirus. So, if a patient is presenting with acute otitis media, this is what one might observe within the ear. So as you can see, that tympanic membrane and the eardrum is going to look swollen and inflamed, and there will be an infected fluid in that middle ear portion. Now, before actually treating the infection, we have a few things to consider. First, we want to consider, could this infection be caused by a bacteria? Typically with bacterial acute otitis media, this presents with more severe symptoms. For example, you might see a higher fever or more pain associated. Also with a bacterial infection, without treatment, we might see worsening of symptoms over a few days, whereas with a viral infection, oftentimes if there's no treatment, it will start to resolve itself in a few days. Another sign might be from the ear drainage. It is known that with a bacterial infection, sometimes that drainage from the ear does have a foul smell. In some cases, doctors may drain some fluid in the middle ear using a tiny tube to pierce the eardrum to test that to see if the liquid does have bacteria in it. And then lastly, something that we might want to think about when considering if it's bacterial would just be looking at the patient as a whole to see if they're presenting with any other symptoms that might point to a viral infection such as RSV or COVID. Now, if a case is likely determined to be bacterial, when do we want to use antibiotics? According to guidelines, antibiotics should be used for a child between the ages of 6 months to 2 years when there is drainage, when there's a bilateral infection, or when there's a unilateral infection with severe symptoms. They are to be used for a child older than 2 when there is drainage, or when there's a bilateral or unilateral infection with severe symptoms. When do we want to wait and see if symptoms will improve on their own without using antibiotics? This would be when a child is between the ages of 6 months to 2 years and has a unilateral infection with no drainage and mild or no symptoms. This would also be for a child older than 2 years when they have a bilateral or a unilateral infection with no drainage and mild or no symptoms. So according to guidelines, I wanted to go over what the severe symptoms are that might lead us to decide whether or not to use antibiotics. So these are defined as persistent ear pain that lasts longer than 48 hours, a temperature of greater or equal to 39 degrees Celsius, so that is 102.2 degrees Fahrenheit, within the last 48 hours, or an uncertainty about access to follow-up after the initial visit. So this might be, for example, the inability for a patient to return if symptoms worsen in the next few days. So, if we are going to use antibiotics to treat our patient, what are the treatment options? First-line antibiotics for acute otitis media include amoxicillin and augmentin. Amoxicillin dosing would be 80 to 90 milligrams per kilogram per day in 2 divided doses. Second-line therapies are going to be ceftonir, which would be dosed as 14 milligrams per kilogram per day, once a day, or in 2 divided doses. Could be cefuroximine, which would be 30 milligrams per kilogram per day in 2 divided doses, or cefpodoxamine, which would be 10 milligrams per kilogram per day in 2 divided doses. This second-line therapy is usually recommended when a patient reports a penicillin allergy or when amoxicillin has already been used for a patient within the last 30 days. There is also third-line therapy, and this might be used if a patient first does not respond to an amoxicillin after 48 to 72 hours, and usually if that's the case, they will switch to an augmentin. This also could be used if a patient does not respond to one of the above therapies. So if they don't respond to those second-line agents or one of the first-line agents, you could try ceftriaxone as a 50 milligram IM or IV for 3 days. And then lastly, if a patient has an allergy to cephalosporin, you could try a clindamycin, and that would be 30 to 40 milligrams per kilogram per day in 3 divided doses for 3 days. Now, on the last slide, I did not touch on duration except for those special third-line treatments of ceftriaxone and clindamycin, and that is because the duration of these oral antibiotic therapies varies based on the age of the child. As you can see here, children under the age of 2 years old are recommended to be on the oral antibiotic therapy for a full 10-day course. It is recommended that children between the ages of 2 and 5 are on oral therapy for a 7-day course, and then children older than 6 years old have the recommendation of being on oral therapies from 5 to 7 days, but 5 being that minimum. And when looking at this duration, I am looking at day 1 being the day of diagnosis and the first time you're going to take antibiotics. And then with most people, they can expect some symptom relief starting around 48 to 72 hours. So that should be felt by day 4. And if not, a patient should be considering going to the doctor again to be looked at. Here are the sources used for this video. And finally, thank you for listening. If you have any further questions, please feel free to reach out to Emily Perry with the NDSU CAP Center. Her email is listed here.